Hello, welcome to the Massachusetts General Hospital Frontal Temporal Disorders Unit Community Forum Friday webinar series. My name is Katie Brandt. I'm the Director of Caregiver Support Services and Public Relations, and I'm honored to welcome you to our program today, Understanding Brain Donation, a conversation with Dr. Matthew Frosh. This is a special Community Forum Friday session. It's actually a recording of a presentation that we did for our Boston area FTD caregiver support group. Many of you who are watching this program have attended our online caregiver support groups. And you know that while we usually use that time to connect as peer caregivers to share emotional support, information, tips and tricks, occasionally, we also bring in community experts and speakers to talk about relevant topics. This was a conversation that was so good and addresses such a sensitive and important topic for families that we knew we had to bring it to a wider audience. So it's my privilege today to introduce Dr. Matthew Frosh. Dr. Frosh is the Lawrence J. Henderson Associate Professor of Pathology, Associate Director of the Harvard-MIT Division of Health Sciences and Technology, and the Director of Neuropathology Service at Mass General Hospital. In addition, Dr. Frosh runs the Frosh Lab, where he and his team are working to understand neurodegenerative diseases, particularly cerebral amyloid angiopathy, Alzheimer's, and Parkinson's diseases. Dr. Frosh also directs the Neuropathology Corps of the National Institute on Aging-supported Massachusetts Alzheimer's Disease Research Center. Over the years, I personally have benefited from learning about brain donation and the irreplaceable gift that it is for Alzheimer's disease and related dementia research from Dr. Frosh. You'll see that he brings wisdom and compassion to this subject for families. And I hope that the information that he provides answers your questions about this very important topic. Thank you for being a part of our session today.
Oh, great. Well, thank you, Katie, and hello to everyone who's joined us today. So as Katie explained, I really am the center point for really making available both diagnostic information to families and tissue for research. And I want to emphasize that those are two very separate, but I think in many ways equally important aspects of what comes from the brain donation program. As Katie mentioned, my many roles include being the director of the Neuropathology Corps, and that Corps is part of the Alzheimer's Center. But we really are interested in the broader concept of Alzheimer's disease and related dementias, the AD-RD spectrum, which includes the frontotemporal degenerations. And we really see ourselves as serving families and the physicians who take care of them, the physicians who oversee research projects with them, and the community that's really using tissue to understand disease biology better with the goal of developing better diagnostics, better therapeutics, and even preventive approaches. And I think that if one looks, leaving aside the current controversy about the Biogen drug, but one looks at what's gone on in Alzheimer's disease in terms of imaging methods, CSF and blood-based biomarkers, and therapeutics, it really does demonstrate the path forward for other disorders to build off tissue. So let me just say up front, I think, and we feel very strongly that a brain donation is really an enormous gift and real massive contribution that families and individuals, to the extent that they participate in the discussion and wanted to act on it, can really make in support of research. I mean, I think especially for those affected, both as the directly and indirectly as caregivers, family members, friends of people with FTD, there is still uncertainty about exactly which of the various flavors of the disorder any individual might have. Those different flavors come with different implications for types of diagnostics, types of therapeutics, and potentially also for types of genetic risk for others in the family. So really getting a sort of hard answer that really only neuropathologists can give by actually looking at brain tissue. Is this someone with deposits of tau? Is it someone with deposits of TDP-43? Is it someone with one of the other much less frequent forms? And also, are there other things that have contributed to someone's impairment? Really allows families to have a better understanding of what the disease was, but also for the clinicians and neurologists and others who work with those affected to really understand, were the therapies that they were trying going to be effective or not? If you think about someone who has a mixture of disease processes, being able to know that that was present and might have influenced what went on in a clinical study is important, but it also allows physicians to go, oh, I can now learn how to begin to separate people who've got just TDP-43 from some TDP-43 and some vascular changes from their hypertension and diabetes, and really begin to understand what's gone on for any individual who they cared for. So that's the diagnostic. And the piece that we do as a service there is that the family and the physicians will get a report that explains the diagnosis. It's in very technical terminology, and I'm happy to meet with people, but often the physicians who were directly involved are the ideal people to have that conversation. But that really gets at that part. And that's a direct sort of feedback benefit for families, caregivers, and others who were involved. At the same time, we are also able to, by collecting and examining, and basically what the term we use is banking tissue, make it available for research. And I do like the word bank, because I think if you think about what you do at a bank, you make deposits, you put money in, but if only thing that happened was that money went in, it wouldn't do much. What happens is that banks also lend money. Banks give money out. And what makes them useful is that for deposits come in, and then they go out to be used for other things. And I can't emphasize enough how important it is to have tissue to understand these diseases. No matter what we have done, mouse models, other animal models, cell culture, in a dish, computational models just don't capture the complexity of human brain and the disease of human brain. And for that reason, allowing investigators who have ideas, who have some preliminary data, to actually be able to go in and say, is what I think might be going wrong actually wrong when I look at tissue from somebody with this disease, and does it let me tell me that disease A from disease B, is really an important piece. So I think we take both deposits in and we make lots of withdrawals. And those withdrawals are done, we don't charge people for getting tissue from us. And I think that we are, we support people, as Katie mentioned, all around the world, all across the country, as well as within our institution and the greater sort of neuroscience ecosystem that we live in the Harvard, hospitals, MIT communities. And that's really a massive sort of gift that you give through us outside to the community. What I have to say is that when we bring in an individual and do the autopsy and make the diagnosis, it's sort of in two separate worlds. One is where it's all identified. We know who the patient is, we give back the report, and it goes back to the people who are involved. When we work with the research community, they do not know who any individual is. And that's really important. We only maintain, when we maintain that link and we protect it, but research that gets done is never done on an identified individual. And that means that sometimes people say, well, will I learn what happened? And the rules that govern us mean that we're not able to say that tissue that one per family donated is subject number 4 in this paper and subject number 10 in another paper. We're not allowed to do that. And I think that's important because there's all sorts of potential sort of, awkwardness and uncomfortableness. I think what you can be assured is that we treat all of the cases that come in with enormous respect, and we make sure that they go for research that is appropriate and well designed. We have committees that review it, and it has to have been reviewed by research committees for approval at the institutions that are where it's being executed, but that they get it without any link that identifies who the donor was. As examples of what's been important, I think all of the very important advances in imaging, both structural imaging, MRI, functional imaging, imaging where someone does tests in the machine, and then imaging with new agents, the PET type imaging for A-beta, for amyloid, for tau, and for others. All of those really are validated by autopsy tissue that allowed us to prove that what something was thought to be binding to really is what it was binding to. And that work, our group with cases that came through lots of sources, really helped explain the tau imaging agents that have just begun to become new, both research and are edging towards becoming clinical diagnostics. And I think that, we work across neurodegenerative diseases. We see a reasonable volume of cases of all of these, and we are expert. We sort of provide both the cutting edge diagnostics back to families, and we are able to go back and provide samples for genetic studies if people wish, or as new diagnostics come along, to be able to apply them and follow up back, closing that loop with families. So I think we as the research community are enormously appreciative of your considering, and those who do agree to make the donations. We try to make the logistics of it as simple as possible, and I can talk you through a bit of that. But we have lots of people, Katie is one of them, who is really expert in helping families negotiate this, and it's not hard. It has a couple of steps, but it's not very difficult. And then we really do think that the information that comes back to families is useful, both for sort of as a closing diagnostic, but also to answer questions that couldn't have been answered, at least currently, during life. I'd say the research is focused at making more of those questions answerable when people are diagnosed. And that really is the goal, is to improve diagnostics so that we can sort people into the right columns so that they can get what we hope will become effective therapeutics. So we're really working hard to think about how tissue gets used for diagnostic purposes as early diagnostics, screening, and then as those diagnostics get used as surrogate markers for treatment trials. We're all very comfortable with the idea that you can manipulate somebody's cholesterol with statins and other drugs. And those statins were designed not just for the cholesterol effect, but really because they protect you against heart attack and stroke. But they were found to be effective, and they were approved because it was clear what they did for cholesterol. And everybody knew that improving your cholesterol was good for protection. And so we're really working to find the cholesterol equivalent for Alzheimer's disease, frontotemporal dementia, ALS, Parkinson's, Lewy body disease, and so on. And having said that part of sort of my pitch, I think I will stop. I'll give it back to Katie. I saw some questions popping up. I'm happy to answer questions, and I know some people submitted some in advance. But I'm happy to sort of make sure that the rest of the hour goes where people would like it to in terms of answering and addressing questions.
Dr. Frosh, that was a incredible overview, but you touched on so many important aspects. The idea that brain donation helps with diagnosis. It connects us with an international community, and it can also provide closure and even potentially future information for families as research advances. I want to say I was especially touched by the idea of that information from a brain donation is shared anonymously with the research community. Because one of the things we talk about a lot in support group is this idea that we don't have a cure today for the diseases, but we have a cure right now for the isolation and loneliness. We have a community of supports. And to me, just hearing that idea of contributing to the community of scientists feels like a bigger extension of that. I'm really inspired by that idea.
No, you're absolutely right. I mean, there are lots of investigators who are really committed to better understanding of these diseases.
Yeah.
And one of the limiting factors is really the availability of tissue. And I think that the investigators are very appreciative of it, but they also recognize what it takes for that to be available to them. And they too sort of recognize the contribution that it has made, and are, and really do have a sense of appreciation for that. It's very different than, and they understand how different it is than working in mouse models and the like. And I think that their sense of urgency is in part driven by their commitment to the disease, but also by recognizing that when they work with tissue, it's for people for whom they didn't get to an answer soon enough.
Right.
And I think that really is sort of, that propels people forward.
Yes, these are families, many families that are still waiting. So this, I think, is a good segue to one of the first questions. Who is eligible to donate their brain to the MGH brain donation program? And Dr. Frosh, could you just say, what is the name, like when families want to tell their family members, where did they donate their loved one's brain if they donate it to our program?
So in our program, we actually hold all of them within the Alzheimer's Center, because it really is Alzheimer and related disease. And we're fortunate that we have been funded by the National Institute of Aging at NIH for almost 40 years now. And that provides us with some infrastructure so that we have staff and people who help do that. And it is done through the MGH autopsy service. So it is a clinical MGH report. If someone's been followed at MGH, it will actually end up in their medical record, so that it is always retrievable in that way. So who is eligible? Well, anyone who is a MGH patient, whether or not they've been followed in the frontotemporal unit. Clearly, anybody who gets their care in the frontotemporal and or participates in research. And I do want to say we are particularly committed to providing this service and tracking people who do participate in research because of the added information that we gain from the diagnostic side. If somebody's been in a clinical trial, it's really important to be able to come back and say, yes, and the diagnosis you thought you were treating really was there. We do not charge for doing the autopsy. And I think that's really important. We don't charge. I think it would, personally, I think it would be immoral of us to charge if we're going to basically be taking advantage of this for the research community. The same way we don't charge researchers to get tissue. The only place where issues come up, and for the most part, those who are followed in the FTD unit, patients with Brad Dickerson and his colleagues, The one cost that we cannot always cover has to do with transportation, bringing the body from home, nursing home, hospice setting, to MGH for the autopsy. Almost much of the time, I think that there are funds available, but that's a conversation that the families contact either Katie or Dr. Dickerson or me indirectly, and we have a conversation about it. And I think we are almost always able to do that, but I can't guarantee that. Those who are part of our research cohorts, we do have separate funding for that transport. If people are very far away from MGH, that just becomes logistically difficult. But I'm fortunate. I'm well connected in the neuropath community. I'm former president of our national organization. And if people, for example, used to live in the Boston area and have moved to be near family elsewhere, to sort of broaden the caregiver spectrum, and we know that this happens, I can usually find colleagues who will work with me to sort of make and facilitate a donation through to us. So I think, people with no connection to our institution, it's much harder to incorporate. But even there, sometimes we can do that and like, so it's always useful to have conversations in advance of the moment when a decision needs to be made. It just allows us to sort of do some planning, and it allows people to sort of get things lined up. Like everything else, at the moment of someone's passing, all of your thoughtful, well-organized plans really feel like they fall apart. And we on the side who are getting the autopsy consent and making the arrangements fully recognize that this is, no matter how much anticipated, it is always very different in the moment. And therefore, the more we do and discuss and have everything sort of organized so that all that needs to happen is one phone call, the better. And I know Katie can speak to the work that she's been doing to help get things organized and really have everything in place to make it as easy as possible. I think that really benefits everyone.
It does. And it's really about making sure that our clinical research team knows the wishes of the families that we're caring for and working in research with. Because if we know that a family wishes to donate their loved one's brain, an individual wishes to contribute to research in that way, then we can help with some of that coordination and facilitation. When families are in the planning stage, I can talk with family members. I can talk with funeral home representatives. And sometimes I'll talk with hospice staff or skilled nursing staff so that there are other people available to make that phone call. Mm-hmm. And just thinking a little bit about the logistics and that planning, we, as you mentioned, Dr. Frosh, we recognize this is an incredibly emotional decision for many families. And one thing I have advised families is, if you're a member of our clinical research program, and let's say something unexpected were to happen, and you say, you know what, I didn't do the paperwork ahead of time, I guess I can't do it. I would say, give us a call. We've helped many a family. And I think that your team and ours, we're really dedicated to helping folks fulfill those goals and those wishes, if that's the case.
Right. And I would say we actually have someone on call 24/7.
Yes.
Who can answer. They won't do something, but they can answer questions. They can make sure that we know about things and that we can sort of start to plan first thing in the morning. So it is, if you're caught by surprise, it's not too late.
It's not too late. And, I think when we think about, it might be helpful to just talk a little bit about what actually happens. You started doing that when you were talking about the costs for transportation. Sometimes families are surprised to know that the funeral home is the entity who's in charge of transporting your loved one from their place of passing to MGH to give their gift. And
Yes.
so, but
So
that's not the first step, really.
funeral homes are the only people who can do that.
That's right.
And I mean, it sounds a little crass, but it's basically like a cab ride to the hospital.
Right.
And
It's like
and
taking a
that's what
ride
it
to
is.
the
It's as though
hospital.
you were coming in for a visit. And in terms of, sometimes people want to know about impact on funerals, on viewing, wakes, open caskets. The autopsy is done in a way that allows an open casket. It allows viewing. We work in a way that does that, and that's true not just for what we do, but for what all autopsy pathologists do. There's a bit of a delay for those where it's usually less than 24 hours, but for folks for whom rapid burial is critically important, especially Orthodox Jews, I know, really want burial within 24 hours. We can almost always accommodate and work with that. I do have to say we had some significant constraints during the height of the pandemic in Boston. And right now, one of the things that we do is we actually swab and screen for COVID before we actually do the autopsy. We just do the nasal swab the way many of us have had on lots of occasions. But that's done mostly to protect the staff who are going to be in doing the autopsy. So basically, if someone, say, passes at home, the goal is that the family contacts the funeral home and says, we've arranged for a brain donation autopsy at Mass General. The funeral home will bring the body to MGH. We do that autopsy. We typically get it done within 6 to 8 hours of arrival. Sometimes it takes us till the next day. We do them over the weekends. And then the funeral home removes the body back to the funeral home now to make whatever arrangements would have been done anyway. And those can be as they were. So we're essentially a medical visit in the middle of that. And that's why, in fact, it is actually, just so that people are aware, that consent for the autopsy comes from the healthcare proxy. It's like another clinical test because you will, in fact, be getting a clinical diagnostic report back. And then if there, I mean, I would guess that for all of those, any individual we're talking about here, almost all of them will have a healthcare proxy. But I do want to say that the other thing that is just as important, and sometimes when I give this talk, people ask me, just as important in order to be able to ask meaningful research questions as having tissue from someone with the disease is having tissue from individuals who don't have disease, and really control donors who sign up and say, you know, my family is committed to this and I would like to be a control, is as important almost, if not more. Because for those affected by disease, there's often a very strong motivation and the like. And for people who are healthy, it sort of doesn't occur. And so we often, you know, turn to, in fact, families of those affected by the Alzheimer's disease and related dementias as our control group. And the same way that people might be in clinical or, you know, behavioral studies and working as a partner in the control arm, it's just as important for individuals who are committed to this as the controls to really try and make that donation as well. And there clearly we are eager to cover transportation costs because the control tissue is harder to come by for obvious reasons in those ways.
And so if someone is interested in being a control, who could they talk with about that? Would they talk with their?
I would say talk with the physician who's caring for in the unit would be the best person, because that can start the conversation, because the paperwork is the same.
Mm-hmm.
And the like, and I know that up in the longitude in the memory disorder unit, it's a pretty common involvement that both the affected individual and the caregiver, who's the regular participant who comes with them to visits, often both agree to participate in that way.
It's another shared experience, the team approach to fighting back against the disease in different ways. That's, again, right, so impactful. I just want to take a step back. As you mentioned, that the consent is provided by the healthcare proxy. So just so families understand, if they haven't had the chance to talk through the process before, typically what happens at the time of your loved one's passing, you make a phone call to MGH where you would speak with the physician on call. And most frequently, Dr. Frosh, that has been a member, it's been a neuropathologist who's been talking with our families. And I just want to share that so many of our families have really been impacted by the compassion and the support that they've been provided from your team members. So I want to thank you for that.
Well, thank you. I'm very proud of the fact that they do a good job at this. It's a difficult thing, and most pathologists, in fact, are not trained to do this, but it's one of the things that we have worked hard to give them the skill set for. It's a short conversation, just so that you're aware. It will be with, in fact, two people at our end. So we have both the person getting consent and a witness over the phone. They'll both be on the call. I'd say the calls typically last no more than 2 minutes. Right. And a little bit of it is just gathering information, making sure that everybody understands what's being done. And then we actually explicitly ask for permission to examine the brain. We ask for permission to do it for purposes of diagnosis. We ask for permission to make use of it in research. And then we also ask, and I think this is also important, we ask for permission to make use of it in teaching. And one of the things that, Mass General is a teaching hospital, one of the things that that is important part of the institution mission and that we're really known for is educating the next generation of physicians across the disciplines. And so whether that's general practitioners who may be seeing individuals in primary care settings, whether it's neurologists, whether it's neurologists specializing in dementias or behavioral disorders, or whether it's pathologists and the like, other types of caregivers, affiliated professionals in the institution, all of those groups benefit from the opportunity to learn in these cases. And so we ask permission for that as well. We sometimes and commonly ask for permission to do eventual genetic studies, but those are research studies. That's not genetic testing with information coming back to the family. Just so that people are aware of that. We can do genetic testing with information coming back to the family, can be organized, but that's separate from the genetic research that is asked for consent for at the time of the autopsy.
Right. And I've worked with families who were patients of Dr. Dickerson's, and they've asked him expressly, will we learn this information through autopsy? Oftentimes when families start asking those questions in life, they get referred to work with our genetic counselor, Diane Lucente, and then there's a conversation that happens there. Right. And I think that it's just a part of the process of understanding what's happening and just really working through the situation together as clinicians. Right.
And I would say, to follow on that, if there is specific clinical type genetic information, genetic testing to be done, we can do it from autopsy tissue. but we again work through Diane Lucenti because it's really important for any genetic studies. I'm sorry, the air conditioning in the building here has been, or the ventilation has been improved to make it safer for teaching at the medical school, but it's very noisy, unfortunately.
No, it's fine, Dr. Frosh, it's fine.
But anytime that we're going to be doing any genetic studies that will give information back to a family, we work with Diane because her input and guidance in interpreting and understanding the information is really essential. And we do that. She works with families and affected individuals as well as through us on the autopsy side.
Absolutely. And so thinking about, we're now talking about learning information from a brain donation. One of the questions that families often ask is, how long does it take to receive a report back after I've donated my loved one's brain?
Unfortunately, longer than I would like. I think, to be honest, we typically tell people it will be about 3 months. We're trying hard to keep ourselves on schedule. I think, sort of 3 to 4 months is about how long it typically takes. There are some where it's faster, and there are unfortunately some that are more complex that require more detailed investigations. Sometimes for the most puzzling cases, I get input from colleagues all around the country or around the world where I will share slides and say, anybody seen something that looks like this before? And look for guidance from my colleagues. I think that the most important thing is that the contact for information coming back to you should be usually we think of it as the primary neurologist who was guiding the care. Dr. Dickerson, others in the unit, or if your care is primarily elsewhere, but you came for more research visits, either one of them. But we do sort of provide the information back to them with the goal of getting it. If you haven't heard, I do encourage folks not to just sort of sit and wait, but call. I mean, if nothing else, I can sort of shuffle the pile and move one case forward and try and answer things. Sometimes families are going to have a family gathering and they'd like to have it in advance. So, if somebody says, in a month we're going to be having that, we can try and time it. Sometimes, families are going to be together again at Thanksgiving and would like to be able to sort of at least say something. So we can try and work to that. It is a long and complicated process that we go through. So it is longer than the simple surgical specimen. If you have your appendix taken out, you get an answer in 4 days. This is a significantly more complex process that we go through.
But to think about that, Dr. Frosh, right from the beginning, that you are potentially collaborating with other experts in the field, the time and attention given to a single case, I think that right away is so impactful. And the idea of that it also is a learning tool for individuals at the home institution, right away, it's making an impact.
I think the same way that if anyone, for example, has had the experience of coming in and medical students or residents being asked if can medical students come into the room while we talk today. That's when people agree to that, that's an important part of the education for that next generation. And I really do think that as I get grayer and grayer in my job, it's part of my responsibility is what I'm doing today, but a large part of it is making sure that there are people who will come and do what I'm doing into the future, and that they will be informed about these diseases and informed about what we're doing so that they can sort of move that forward.
Yes.
It really is. It's a combination of both doing the best we can right now and allowing people to learn to do better in the future. both for diagnostics and for care design and treatment trials and so on.
We have a good question in the Q&A, and just as another reminder, if you have a question for Dr. Frosh, put it in the Q&A. I'm monitoring those. You're doing a good job answering them. Must be just by ESP, what our caregivers are wondering. But there's a specific question. We talked about how you'll share tissue for research and educational purposes. There's a specific question. Do you share tissues with industry partners, for-profit companies?
So we do. It is a significantly higher barrier for that sharing. So for us, if a professor at University of Chicago emails and requests tissue, basically we need to see something about what their experiments are. We look at it to make sure it looks like it's a good experiment. We need to see that they have approval from their institution to use human tissue. And then so long as we can do that and it meets what we view as our mission, we provide it. For industry partners, there are stricter requirements that basically govern the fact that and so the other thing I'd say is that if we give tissue to anybody, an academic collaborator or an industry investigator, they can't give it to someone else. So everybody is only one step away from us. They don't have the right to then redistribute. Everybody has to come back to us. There have to be what are known as material transfer agreements for industry, which govern what happens if there turns out to be an income stream generated from something. And we do collaborate with industry. It's actually harder, in part because they don't want to tell us exactly what they're doing.
Right.
And so there are all sorts of rules about it. And there are often so-called non-disclosure agreements where we have to say, we won't tell anybody what their experiments are, but we still do have to decide that they are valuable and the like. We do work with industry. We work with both big pharmaceutical companies as well as small startup, very innovative companies. I would say that 90% of our collaborations are with academic institutions in this country and elsewhere. And I think that I think industry tends to pair with some of the banks that are run in a for-profit manner because they're running a business, and the business-to-business type relationships are much easier for both sides to handle. We're basically an academic nonprofit institution trying to support as much research as we can and as much open information as we can. And
Right.
the non-disclosures and the like make that hard, but they're not they're not a barrier completely. They're just a slightly higher wall to climb.
But again, just this incredible network of academics, clinicians, scientists, industry partners, and at the center of it all, patients and families. At the beginning, we mentioned that your program is funded by the National Institute on Aging, which has funds that have been increasing due to patient advocacy over the years. Now, over $3 billion a year is dedicated to the National Institute on Aging for Alzheimer's and related dementia research. And I just think that families play such an incredible role. Sometimes they think, well, I'm not a scientist, I'm not a doctor, what can I do? I can't write a big check. But to give this irreplaceable gift, this precious one gift, only the gift that someone gives of brain donation, no one else can give that gift because your brain is uniquely yours. And so when I think about it, it is such an incredible part of my job. And I'm so proud to be connected with your team as well for it.
We appreciate, I mean, I do want to make sure everybody realizes how important Katie has been in the national level in the ADRD community, for which it's an enormous amount of credit and responsibility. But that, you know, there really is, there's an enormous sense of urgency. I think, you know, clearly families and individuals feel it, but I think, you know, we do as the clinical community, and NIA and NIH do as well. And I think that that's been reflected in there. I mean, lots of people lobby,
Right.
but this was lobbying that actually worked. And I think that was because the need is just so large, and the unmet needs for care and support just continue to grow rather than getting smaller.
They do. So I know we're getting close to the end of our time, I just wanted to pay attention to a couple of questions
Sure.
that we didn't exactly answer. So one is, if my loved one has a confirmed case of COVID at the time of passing, are they still eligible to donate their brain?
Yes, so they absolutely are. We do autopsies on individuals. We did many on people who unfortunately died during the peak of the pandemic. I think we learned an enormous amount about what happens to the brain in COVID, in fact. But it does not mean that one cannot. We do it slightly differently with precautions essentially to cover us. There's slightly different rules about how we use tissue, but you will still get a full diagnostic. And there will also be information in that report about whether there were consequences for the brain from the COVID infection, either directly or in the setting of COVID. Most of the changes we've seen have been secondary. They've not been with direct brain infection and the like. But it is absolutely, well, hopefully it will shortly be a unnecessary question to ask.
Right.
We can hope as everyone, more and more people get vaccinated. I think we're all very optimistic that we're going down to a very sort of low level, but the recent data everywhere suggests that we're going to have one more bump at least, unfortunately, hopefully small, at least here. But it is by no means any exclusion, nor are other infections. So sometimes people have had hepatitis, Hep C, that has not been treated, HIV, TB, absolutely nothing. If somebody has cancer, that's not a problem. We will be able to tell something about that. But I will say that if there are other, for people who get their care at MGH, if there are other medical issues that you think having an autopsy would be informative about, we can do a full autopsy. So if there were issues about undiagnosed or unclear heart disease, lung disease, liver disease, kidney tumors, any of those sorts of things, we can do a full autopsy, which gives you not only the brain donation, the brain diagnostics, but the rest of the autopsy diagnostics. And sometimes that's often of value to families about unresolved issues. I think especially in the setting of somebody with a progressive behavioral disorders and FTD, sometimes other aspects of care get put aside and diagnostics get put aside because they become less pressing in the context of what you need to do to sort of help somebody sort of day by day. And so those questions that might well have been addressed through regular care in one way are just left unanswered. And we meaning pathologists in general, me and my colleagues, can try and answer some of those questions as well.
So if a family has questions or desire for a full autopsy, is that something they should talk about at the time of consent?
They should absolutely, at the time of consent, they can say, we're interested in a full autopsy. Is that possible? And we usually are able to say yes.
And would there be an additional cost to the family?
No, there is still, so long as they are an MGH patient, there's absolutely no cost.
Thank you, Dr. Frosh. And I think we talked about this a little bit. One of the caregivers is asking about the range for brain donation. And again, I have worked with some families in the greater New England area who are willing to have their funeral home travel a distance. But I know you have helped me to coordinate other gifts where someone is able to donate their brain at a local institution, and then the brain is safely transported to
Right.
MGH.
Absolutely. When I think about the sort of normal sort of circle inside which sort of, Southern New Hampshire, Rhode Island, all the way back out, really almost out to Albany, that sort of Western Mass edge of New York State is sort of the range where we think that it's probably easiest to get someone brought by funeral home to MGH.
Right.
Further away, way upstate New York, northern Maine, down in the New York City area, I work with colleagues, and we've done this on numerous occasions. It is the situation where knowing in advance allows me to get things put in place. Sometimes on a Friday night, I can't find my colleagues. They're not at their desk and then the like. But if we have a week or two, or even 8 months, and all we need to do is find that email trail of who said what, then we're able to do that. And I think that it's again it's one of those situations where thinking and discussing it in advance really does make things work both more smoothly, but also sometimes is the only key to getting it done.
And that probably would add a little bit of time sometimes to the process. But again, that could be discussed with the pathologist on site, the funeral home. I find that people are usually really good about talking about how long things take.
Right. And, I think we are all, the funeral homes, the pathologists, we're all interested in doing things as quickly as we can within our own physical constraints. So in some places, the autopsy service is not open on weekends.
Right.
And that's sometimes just a constraint that we have to live with. But others, it's not. And I think that everyone understands family senses of urgency and loss.
Yes.
And this is, for us, it is for any individual, for any family, it's a sort of singular event. But we sort of experience it indirectly over and over again. And I think that allows us not to become desensitized, but to really become very attuned to the issues and the concerns. And I think that when things don't go as we want, we really feel it almost as painfully as families do. We really are working to sort of make this work as best for them as we can. That's really the central goal.
And I have seen your team go above and beyond multiple times, Dr. Frosh, you especially included. So just to clarify two things as I'm watching the Q&A. So it potentially could take additional time if a family requests a full autopsy, but your team would be able to communicate that to the family.
We would definitely. So we usually can know roughly how long it will take, how much extra a full autopsy would take. And I think, I know from having spoken with family members who made decisions that sometimes, I think it's worth thinking about this. Again, I think the advanced conversations really do make a difference, because sometimes people make decisions and then afterwards, almost always, I don't know of anyone who has regretted having had the brain donation and autopsy done. I do know people who didn't and now wish they had. And it just, in the moment, was too overwhelming to think about it for the first time. And I have had several follow-up conversations. And I understand that the stress and sort of sadness of that can really, in the instant, in the immediate, moment, really can overwhelm. And I think that sort of having this sort of planned, really, when that dust settles, a month later, really does sort of give something back, I think, and really gives families something else to hold on to.
And that's why we're doing this type of session, because for many families, and I just want to say this will be recorded. It will be presented again during our Fall Community Forum Friday series, and then it will be on our MGH FTD unit YouTube channel. And for some families, it's less, I guess, upsetting, rather than having a conversation with your provider where you really have to talk about it. You could watch this program and just be by yourself, watch it, think about it, and it's less pressure. That's what we hope. So that information is there. And you did say one other thing that I just want to clarify, Dr. Frosh, about how the neuropathology service is not there on the weekends.
Nope. No, we are available. So at some places, if I'm trying to arrange it in, Nebraska,
right?
Not everybody works the same way we do. But here we will do these. We will do the brain donations 7 days a week.
I just wanted to clarify that, because I've had families worry.
Right, and we are always available, and there's always one of my fellows on call, and if I'm not out of town, my pager is always on, and people know how to find me, so that there are always ways to reach us. And one of the things that happens as part of those conversations is to give there's an informational packet. Right, Katie? And
Yes.
that includes how to contact us.
Oh, absolutely. We have an informational packet. I talk with families one-on-one. I send emails. I've even helped folks put the phone number in their cell phone as a contact. Whatever families need, I've texted people information. We talk about it ahead of time, but as you mentioned at the beginning of the program, sometimes in the moment, people just need that one-on-one support to kind of make the final phone call. Yeah. Is there anything else that you would like to share with our community today, Dr. Frosh? You've been so generous with your time.
I think that you should know that we, as the research community, are enormously appreciative of your willingness to consider this and then to do it. And that we, along with the physicians who you see and the other caregivers and support folks, are really working as a large, cohesive team to really address the critical issues in these devastating diseases. And I think that, it is only through the combination of all of us and all of you that we'll begin to make the progress that's needed.
I think that sums it up beautifully. And I really love the idea that we're all working together to ensure that the cure of tomorrow is not so far from the care of today. So thank you, everyone, for listening. Thank you, Dr. Frosh.
My pleasure. And I hope that this was helpful for people. And I wish you all the best.
Thank you so much. Thank you, everyone, for tuning in. The Mass General Hospital Frontotemporal Disorders Unit is a clinical research program committed to providing the highest quality of care while we work tirelessly for a cure for Alzheimer's disease, frontotemporal dementia, and related disorders. Please follow us on our MGH FTD Unit YouTube channel. We look forward to seeing you again. Thank you.